is instrumentation may cause bleeding, or there may be other medical causes or other systemic causes which may cause uterine bleeding. So these are some of the differential diagnosis of post-menopausal bleeding. If the patient is bleeding after the menopause, it is something to be worried about, because once the cycle stops, there must be no bleeding. But if there is bleeding, there are certain causes. You have to start with the infections and then go for uh, causes like malignancy. So start with the common cause first and then go for malignancy. So atrophic vaginitis, endometrial polyp, endometrial hyperplasia, hormonal imbalance, or patient may be taking hormonal therapy after menopause, and then endometrial carcinoma or a cervical carcinoma. These are just to show you some of the drugs that may cause abnormal uterine bleeding, not in all patients, but in susceptible patients, or related to the dose or duration of the medicine. Endometritis means inflammation of the endometrium. Endometrium is a cuboidal to columnar lining, depending upon the stage of menstrual cycle. And then there are glands invaginating into the stroma, endometrial stroma, which may change their shape according to the cycle, or the time of the cycle. Inflammation can be acute or can be chronic. In cases of acute inflammation, you have neutrophils. Acute inflammation is related to bacterial infection. This may be part of pelvic inflammatory disease. That means that apart from endometrium, uterine, fallopian tubes, cervix, vagina, or ovaries may be involved, or endometrium may be having an ascending infection from the vagina or the cervix. So, in cases of acute endometritis, if you take a biopsy, you are going to see neutrophils. So, you don't actually take biopsy in cases of acute infection. A history and examination and colposcopic examination showing discharge or pusty discharge may lead to the diagnosis. In cases of chronic endometritis, one of the cause is bacteria causing chronic pelvic inflammatory diseases like syphilis or gonorrhea that may become chronic. And one of the other important cause is extrapulmonary tuberculosis. So, genital area or genital organs can be involved in extrapulmonary tuberculosis. So, endometrium or stroma of the endometrium can show granulomas or caseating granulomas in cases of chronic endometritis. If we take a biopsy in cases of chronic endometritis, you must see plasma cells. Plasma cells are the last to come into play in chronic inflammation. Why we are not considering lymphocytes? Because, as I told you in third year, and you know from your histology, that normal stroma of the endometrium contains lymphocytes. Because of the normal cyclical bleeding, there are always numerous lymphocytes to maintain the environment and to protect the endometrium against the intruders, or as a local immune system. So, for diagnosis of chronic endometritis, you must see plasma cells. Then only you can say that it is chronic endometritis. In case of acute, you must see neutrophils. Neutrophils and plasma cells, they are not normally present. You may see a lot of lymphocytes in the normal endometrial stroma. So you have endometrial surface, which is cuboidal to columnar. Then you have endometrial glands, and this slide shows a secretory phase. Then you have endometrial stroma. Stroma contains stromal cells and lymphocytes. That is why on staining it takes hematoxylin stain and looks purple. In cases of acute endometritis, you see neutrophils. So you can see a lot of neutrophils here, and you can see neutrophils in the lumen of the gland, which is going to appear as pus if there is a discharge. You must see plasma cells. So this is a plasma cell in the endometrial stroma in cases of chronic endometritis. These pink, they are RBCs, and you have stromal cells and lymphocytes. So this is a plasma cell. This is a plasma cell. So the diagnosis on this slide is chronic endometritis. In cases of chronic endometritis, if you give this diagnosis, the patient is going to go for a long period of antibiotics. So one should be cautious in reporting chronic endometritis because the patient is going to have a long period of antibiotics. Endometriosis is another inflammatory condition in the genital tract in females. Endometriosis means presence of endometrial gland and stroma outside the endometrial cavity. So, from the normal site, if the endometrial glands or stroma is present anywhere else in the genital tract or outside the genital tract, we are going to call it endometriosis. The most common site or abnormal site, or if I say ectopic site of endometrial gland and stroma, that is ovaries. So you may have endometrial tissue in the ovaries or on the ovaries, in the fallopian tube, in the cervix, in the vagina, and then in the myometrium, which is not the normal site of endometrium. You may have other odd sites where endometriosis may occur, and the most common is the abdominal cavity. So you may have endometriosis in the peritoneal cavity, in the omentum, on the wall of the intestine, on the abdominal wall, sometimes in the scar of the previous cesarean section or any pelvic surgery. We have seen some rare sites where endometriosis can occur. One of our patients showed endometriosis in the nasal cavity, and the patient presented with abnormal epistaxis, and the biopsy showed endometrial glands. So it was something developmental, and she was a young patient with recurrent epistaxis, and that epistaxis was related to the cycles of the female, and she was not having bleeding before the uh, cycle started. So it was a cyclical bleeding or epistaxis from the nose. So this is one of the rare sites. You may have endometriosis somewhere else also. So the most common ectopic site stays the genital tract. So other than the endometrial cavity or the normal side of the endometrium, if you have endometrial glands or stroma it is endometrial glands and stroma. It is must that you must have endometrial glands surrounded by a stroma, then only you are going to call it endometriosis. If you have glands only, then you must check for endometrial carcinoma. So a normal gland surrounded by stroma is endometriosis. Endometriosis, or this focus or ectopic focus of endometrial glands will respond to the hormones as the normal endometrium will. So there is going to be a proliferative phase, a secretory, and a luteal phase, and then the menstrual phase. But if the endometrium is contained at a place where the blood cannot go out of the body, the blood is going to stay there and get clot. So whenever there are lot of cycles, the blood will clot, the blood will get degenerated, and it is going to form a thick brown hemosiderin. So uh, the site of endometriosis is going to show you brown colored blood, which is actually a degenerated blood. So why there is endometriosis? There are certain theories, and one of the most common one is a retrograde menstruation. So during the menstrual period, or during the menses, if uh, there is retrograde, uh, if there is retrograde menstruation, or if there is retrograde spread of the portion or part of the endometrial glands into the fallopian tube or on the surface of the ovary, that may form an endometriotic focus. There may be hematological or lymphocytic spread also. Coelomic metaplasia, that is one of the developmental causes. Genetic or immune factors, these are some of the minor causes. So retrograde menstruation is one of the common causes, because in a normal menstrual cycle, the blood is coming out of the body. The blood doesn't stay there in the endometrial cavity. But in case of an ectopic focus, whenever there is blood, it is going to be identified as a foreign substance for that tissue. So, whenever there is a foreign substance, there is going to be an inflammatory response, because that blood cannot ooze out of the body or that tissue. The inflammatory response is going to stay there, and it is going to cause pain, swelling, and all the signs of inflammation. There is going to be a healing process after the blood clots and degenerates, and during the next cycle there is again going to be a bleeding, and the same cycle continues. So this is a retrograde menstruation. So retrograde menstruation causes ovarian endometriosis, and inflammation, as we did in the third year. All the mediators released during the inflammation are going to cause a swelling, bleeding, a swelling, pain, and uh, a focus of lesion in the female patient, and the patient is going to present with an abnormal swelling in the abdomen, or the ovary may get enlarged. So this cycle continues. There is proliferation, there is angiogenesis, there is inflammation, there is macrophage activation, and then there is fibrosis. The cycle again starts in the next menses. So these are some of the sites where you may have endometriosis or ectopic endometrium. So ovary is one of the common sites. Then you may have endometriosis in the broad ligament. You may have endometriosis in the cervix, and in the wall of vagina. These are some of the other sites, rare sites. You may have endometriosis on the wall of the intestine, in the peritoneum, and in the pelvic region. So, a continuous gripping pain, backache, heavy irregular periods, lower abdominal pain, diarrhea, or altered bowel habits may indicate an ultrasound. So, you may find a swelling. The ultrasound is going to show you a blood filled cavity, or it is going to show you a thick uh, fluid in the cavity, which is actually the degenerated blood. This is a laparoscopic view showing you endometriotic foci on the peritoneum. So whenever there is bleeding, uh, here there is fresh bleeding, and these are the degenerated foci showing you hemosiderin. So if you have the endometriotic focus in the ovary, and a continuous bleeding will form a swelling, and this hemosiderin will uh, color the uh, degenerated material brown, and this is called a chocolate cyst. It is just because of the color of the degenerated products which stays there, and it is colored as dark brown material, so it is called chocolate cyst. So a chocolate cyst is nothing but a cyst having blood which gets degenerated and form a thick material. We call endometriosis uh, for ectopic endometrium, endometrial glands surrounded by stroma anywhere in the genital tract or outside the genital tract. Adenomyosis is a term if you have endometriosis in the myometrium. For endometriosis in the myometrium, you call that focus as an adenomyosis. So, adenomyosis is nothing but it is just an endometriotic focus in the myometrium. So it will act same as we did in the previous slides. So these are the foci of adenomyosis. So adenomyosis is actually endometriosis in the myometrium. You must not have a connection of this focus with the endometrium. So this focus is separate from the endometrium, then only you will call it adenomyosis or endometriosis in the myometrium. So see this, you have smooth muscles all around, and then you have a focus of endometrial glands surrounded by stroma. Whenever it is going to bleed, it is going to show you this bleeding, and then brown colored foci in the myometrium. See this, you have endometrial glands surrounded by endometrial stroma, and these are the normal smooth muscles of myometrium. So in cases of adenomyosis, the symptoms may be bleeding or passage of clots, pain or tenderness. Then ultrasound findings may show you asymmetrical thickening or brown colored cyst formation in the myometrium or brown colored small foci. Physical examination may show tenderness in the uterine body, and then you can go for hysterectomy according to the age of the patient. Other benign lesions of endometrium, one of the common is a polyp. A polyp is a growth which is having a stalk and a globular head. So this globular head is made up of the endometrial glands and the stroma, and you have a stalk. Sometimes the polyp is in the lower part of the uterus, and that may project through the cervix into the vagina. And if you go for a colposcopic examination, that is going to show you the head of the polyp. The ultrasound is one of the best radiological investigations for female genital tract, and that is going to give you the diagnosis of endometrial polyp. The treatment is a removal of the polyp from the stalk. Though this polyp may be a hyperplastic polyp, or this may be a neoplastic polyp. So, in cases of a hyperplastic or a benign polyp, you just have to remove the polyp from the stalk, and this is the globular head showing you variable sized glands and the endometrial stroma. Endometrial hyperplasia, as we did this in detail in third year, endometrial hyperplasia is because of the excessive estrogen. Uh, the endometrium is uniformly thickened. The normal size of the and or the thickness of the endometrium is 2 to 5 millimeters, or zero point 0.2 to zero point 0.5 centimeters. If the endometrium is uniformly thickened, it is going to bleed more than the normal, because the more the endometrium, the more are going to be the blood vessels underneath. So when there is menstrual phase, the blood vessels are going to get ruptured and there is heavy menstrual bleeding. So endometrial hyperplasia, the patient is going to present with a heavy menstrual bleeding. The cause is estrogen, and the estrogen is excessive than the normal. The cause or etiology can be any abnormality in the hormonal axis, any abnormality in the ovary, which is actually producing estrogen. There may be estrogen secreting ovarian tumors. Then there may be hyper responsiveness of the endometrium to the estrogen hormone. The patient may be taking oral estrogen in the form of oral contraceptive that may lead to endometrial hyperplasia. On microscopy, the endometrial hyperplasia is of two types: simple endometrial hyperplasia or a complex endometrial hyperplasia. And in those, if you have simple endometrial hyperplasia, that may show atypia or may not show atypia. Same way, in cases of complex, it may be a complex hyperplasia with atypia or without atypia. Atypia or atypical nucleus means that the nucleus is enlarged than the normal. If the nucleus is enlarged and the NC ratio is disturbed, that is atypia or atypical morphology. So, if the diagnosis is simple hyperplasia or a complex hyperplasia without atypia, the clinician is going to follow with the medical or hormonal therapy. If it is simple hyperplasia with atypia or a complex hyperplasia with atypia, there must be a strict follow up, because this atypia may convert into a dysplasia leading to an endometrial carcinoma. So this slide shows you a normal proliferative endometrium. This is simple hyperplasia. Complex hyperplasia is that the glands are so much proliferative that there is very scanty stroma. In case of simple hyperplasia, there may be a dilated glands or the number of glands are increased. The normal stroma to endometrial gland ratio in a normal endometrium is 1 to 1. If this ratio is changed and glands are more, it is abnormal. And the first diagnosis is hyperplasia. So this is a simple hyperplasia. You can see number of glands or dilated glands. You may see double layering, which is actually not double layering, but because in cases of hyperplasia, the number of cells increase and they have to reside on the same basement membrane. So you may see nuclei of the cells as double layered. The stroma is scanty than the normal endometrium. So these are some of the dilated glands in case of simple hyperplasia. This is a complex hyperplasia. In case of complex hyperplasia, you have back-to-back glands with a very scanty stroma. So if this is one gland, this is another, they are residing or they are arranged back to back. So this is the endometrial cavity. So this is the gland, and this is the cavity of the gland. You have secretions in the cavity, and you have scanty stroma. This is a high power view of a single gland showing you a number of nuclei, but these are actually residing on the same basement membrane, and this is just a misnomer that the epithelium is double layered. It is just the nuclei which are arranged in such a position that it shows double layering. Coming to endometrial carcinoma, which is a malignant tumor of endometrium, all the endometrial carcinomas are adenocarcinomas because endometrium is a glandular tissue. So, uh, it is one of the most frequent invasive malignancy in the female genital tract, and the pathogenesis remains hyperestrogenism. Endometrial hyperplasia leading to atypia, leading to dysplasia, may lead to endometrial carcinoma. Obesity, diabetes, nulliparity, hypertension are some of the other risk factors. Familial uh, considerations are uh, also there, and there are certain genes which are important like KRAS and P53 genes which are mutated in endometrial carcinoma. So there are two main groups of endometrial of patients showing endometrial carcinoma: perimenopausal phase or older phase, which is the postmenopausal. So perimenopausal phase means that before menopause. It is the most common group showing endometrial carcinoma, and it is associated with endometrial hyperplasia. And it this type of endometrial carcinoma is having a good prognosis, while endometrial carcinoma in the older age is because of hyperestrogenism and endometrial hyperplasia with a poor prognosis. Premenopausal endometrial carcinoma is called type 1 endometrial carcinoma nowadays, and the postmenopausal endometrial carcinoma is termed as type 2 endometrial carcinoma. Both have different prognosis, both have different etiologies, and both have different gene mutations. Both have different treatment, and the prognosis of type 1 is better than type 2. So whenever a pathologist is reporting an endometrial carcinoma, considering the age and the morphology of the endometrial carcinoma, we have to write down the type 1 or type 2, and likewise the clinician is going to treat the patient according to the type of carcinoma. These are some of the risk factors in general for endometrial carcinoma: age more than 40, obese, and ovulatory cycles in young age, nulliparity, infertility, tamoxifen use, which is anti-estrogen therapy. Sometimes you have to give anti-estrogen therapy in breast carcinomas, which may lead to endometrial carcinoma as a side effect. So, if the estrogen receptors are negative in breast carcinoma, the oncologist is not going to go for anti-estrogen therapy. Then, a family history of endometrial carcinoma may cause a familial lineage. The difference between endometrial hyperplasia and endometrial carcinoma is that if the endometrium is uniformly thickened, you you are first going to think about endometrial hyperplasia in a young age. But if you have a focus of thickening, or there is a focal thickening or growth, then you are first going to think about something fishy that may be a carcinoma. So in cases of carcinoma, you may have full thickness carcinoma, but it is not very common. So, endometrial carcinoma is an adenocarcinoma. It may be type 1 or type 2. The morphology of both are different. So, type 1 is in pre-menopausal persons or females, and type 2 occurs in postmenopausal. The growth is slow in type 1, the growth is rapid in type 2. Precursor lesion in type 1 is atypical hyperplasia, while in type 2 it is endometrial intraepithelial carcinoma, EIC, or EIN, endometrial intraepithelial neoplasm. Histologically, type 1 is endometrioid type. The morphology is going to show you resemblance with the endometrium, while in type 2, it is a clear cell carcinoma or a serous carcinoma. Serous means that it is secreting water like secretions or clear secretions. Type 1 is a low grade, while type 2 is a high grade carcinoma. The depth of invasion into the myometrium is usually superficial, or half of the myometrium in case of 1. But in case of 2, as it is a rapidly proliferating or progressing tumor, it is going to invade rapidly and go deep into the myometrium and outside the uterus. P10 or KRAS gene mutations are there in type 1, while P53 mutation is present in type 2. So you have to remember this table. This is from your book. This table show you some of the mutations in type 1 and type 2 carcinomas. Uh, P10, KRAS, beta catenin, microsatellite instability P53, HER2 new P16, and E cadherin are some of the mutations that you may see differently in these two types of carcinomas. And you need a number of mutations to show you a symptomatic tumor. This is just to show you a chart of gynecological cancers and their symptoms. Abnormal vaginal bleeding may occur in cervical, ovarian, uterine, or vaginal uh, tumors. Pelvic pain or pressure may occur in ovarian or uterine and vulvar cancer. Abdominal or back pain may occur in ovarian, bloating, may occur in ovarian because of the pressure on the intestine. Changes in the bowel habit may also occur in vaginal or ovarian because of the pressure or invasion of the intestinal wall. Itching or burning of the vulva in the vulva cancer, and skin changes in cases of vulva cancer. So these are some of the points which you can see in the clinic to come up with the diagnosis clinically, and which is confirmed on investigations. This is a uterus showing you a cut section of the endometrial cavity with a irregular growth. This is an endometrioid type 1 endometrial carcinoma. So there are a number of glands showing you hyperplasia and pleomorphism. There may be atypical mitosis like this, and this. You have very scanty stroma. This is again type 1 endometrial carcinoma. It is in premenopausal females with a good prognosis. A high power view showing you a gland of variable sizes, hyperplasia, pleomorphism, and mitosis. Again, an endometrial carcinoma. This is type 2 endometrioid, type 2 endometrial carcinoma, which is serous and clear cell. So you can see a papillary formation. This is the core, and this is a finger like projection, like a papillary configuration. So you have papillary configuration in type 2 carcinomas. You have clear nuclei in type 2 carcinomas. You may have clear cytoplasm in type 2 carcinomas, showing you a secretory morphology. See this. This is a clear cell type 2 endometrial carcinoma in postmenopausal females. This and this, the papillary or serous and clear cell in case of postmenopausal females, type 2 carcinoma is having a bad prognosis. Again, regarding FIGO staging or FIGO classification of endometrial carcinoma, these are some of the stages: type 1, 2, 3, stage 1, 2, 3, 4. One is uh, invading the myometrium, two is invading the surrounding structure, and the important one is cervix. Stage 3 is when it is invading the fallopian tube or the ovary or the parametrium, the broad ligament, the vaginal wall. And stage 4 is distant metastasis. The lymph nodes which are involved, or which gets the metastatic deposits in case of endometrial carcinoma, are the pelvic lymph nodes. We are going to continue this tomorrow in our lecture on the stromal tumor and the myometrial tumor. So I'm going to stop here for today. We did with some of the benign lesions, the inflammatory lesions of the endometrium, and the endometrial carcinoma. If you have any question, please send that to the CR, and I'm going to answer that. So see you tomorrow. Thank you.